Presenting a new series, Medically Verbal, where we'll solve case history in just a couple of minutes. Disclaimer: these case studies are for understanding purposes. Inaccuracies may be present. Do not attempt these processes without the guidance of a licensed medical professional. Case 16. Chief complaint. A 30-year-old female presents to the clinic with complaints of intermittent abdominal pain and bloating over the past few months. History of present illness. The patient describes episodic abdominal pain that is crampy in nature, located in the lower abdomen and associated with bloating. She notes that the symptoms tend to worsen after meals and improve with defecation. She denies any changes in bowel movements, blood in stools, fever, or weight loss. She does not have a significant past medical history, is currently on no medications, doesn't smoke but uses alcohol occasionally. Father had a history of irritable bowel syndrome. Physical examination shows her BP to be 120 systolic, 80 diastolic, heart rate 72, respiratory rate 16, temperature 98.4. She has a soft, non-tender abdomen on palpation and does not present any mass or organomegaly. Initial differential diagnosis: irritable bowel syndrome, functional dyspepsia, gastroesophageal reflux disease, lactose intolerance, diverticulosis. Based on this presentation, what do you consider the most likely diagnosis and what further investigations or management steps would you recommend? What is functional dyspepsia? When you have a recurring upset stomach, but you don't know the reason. It's like an idiopathic thing. Gastroesophageal reflux disease is basically when the acid gets refluxed in your esophagus itself. That kind of gives you cardiac burn. Diverticulosis, a bulging pouch that develops in the digestive tract. Lactose intolerance, whenever you consume any milk or milk products, you feel pain in the stomach and you have diarrhea after that. It is relieved once the milk product is out. Likely diagnosis could be irritable bowel syndrome because of the symptoms that the patient is presenting. Further investigation that could be done first and foremost would be fecal calprotectin because it would help us to assess inflammation. Now in IBS, which is irritable bowel syndrome, there is no inflammation, but IBD presents with inflammation. That's why fecal calprotectin would be elevated in inflammatory bowel disease. Check the stool sample for any bacterial or parasitic infection. Do an abdominal CT so that we could find any structural abnormalities or any conditions which are similar to the syndrome. We'll perform an abdominal X-ray to see for obstruction. For management, we'll start on with the symptomatic treatment by giving her dietary modifications. Consideration of a low FODMAP diet. What's FODMAP? Basically, the person should not have any sort of sugars which are fermented. We'll provide them with antispasmodics like dicyclomine for abdominal cramping, and for constipation, we'll suggest them laxatives. We'll arrange follow-up so that we could review investigation results and assess treatment responses. Hope you like the case study of today. You can come back whenever you want to sum it up. Please make sure that this is not a substitute of medical advice and is just for understanding purposes of how to diagnose and solve case histories. Thanks for watching. Directions or suggestions, comment down below. Make sure to like, share, subscribe and hit the bell icon to never miss another update.